Good evening, everybody, and welcome to our next Meet the Expert from TOFs. I'd like to welcome Nick, who should be on your screen now, and obviously Diane, obviously who a lot of you know, our CEO. We've done many of these now tonight, so hopefully lots of people will now be already used to taking part in this. But if you're not, and this is your first time you've joined us, then obviously we will ask lots of questions because obviously we've been sent lots of questions to Nick. He's going to answer all of them. However, obviously, if you've got other questions, please put them in the chat and we'll answer as many as we can tonight during, obviously, the hour that we're on. We will finish at 8 o'clock and make sure we're done for that. So pop them in the chat. We'll get around to them towards the end. And if we don't, at some point, we'll get some answers to you so that therefore everybody gets their questions answered. Just a reminder, evaluation form, obviously, please fill that in when you get it after the event, because it's always good to get feedback, particularly if we want to look at, specific topics, and obviously we can look at that. And then our next Meet the Expert is in November when we're talking about the TOF cough and chest infections. So obviously keep an eye on that date, and obviously the obvious will be in touch with you all then. So, Nick, welcome. Thank you for giving your time with us tonight. Your time is valuable and much appreciated. So we'll kick off straight away with the first question and we'll get going. So we've received a number of questions asking how best to manage reflux in babies and children. What might you suggest as a general approach?
Okay, thanks, Duncan, and thanks for having me. I guess the best way to talk about this is to say that it really depends on how old the child is and also what their symptoms are. If it's what we call volume reflux, so particularly seen in babies where you're bringing back lots of feed, lots of milk, that's referred to as vomiting. I mean, strictly speaking, it's not vomiting, it's more of a passive regurgitation of fluid and food. So reflux should be different to true vomiting, which is a coordinated reflex that the body does, to expel something. So reflux, when you bring in volumes of food back or feedback, that can often respond in younger children to fairly simple measures and changes. So, for example, changing feeds, smaller amounts and more often would be the simplest thing you could do to help reflux in smaller children and babies. You may thicken the feed, and it's important to say that different feeds can cause different reflux, and we know that some of the international guidelines now for gastroesophageal reflux talk about the first line is to change the milk. Obviously, if you're breastfeeding or breast milk, that's more difficult, but if you're on a formula feed, different formulas can sometimes be better tolerated. So that's small amounts of feed more often, changing the feed, adding a thickener, for example, Carabel, or using Gaviscon as a thickener, but also as an anti-reflux agent. They can all be fairly simple things. Positioning, being more upright can help. So sometimes we prop the cot up, or if children are older, and that can apply to any age, you can put the mattress slightly up, because a lot of these symptoms of reflux are more troublesome at night. So that's a positioning issue. You can prop the bed up, stay upright, eating and drinking. And while we're talking about sleep, it's probably also important to say that it's a good idea not to eat too late. So particularly older children, it's good not to eat too close to bed, because you find that those symptoms at night can then be worse. Along with those sort of nighttime issues and being flat, we often see that those reflux symptoms, as children become more upright and stronger, and their muscles, their core muscles and their diaphragm and things get stronger, then their reflux symptoms will ease. So they're the simple things we can do. In older children, it's probably also worth mentioning that certain foods can make reflux worse, and avoiding those foods is really important. So that would be things, again, it's slightly individual, but a lot of acidic foods can cause bad reflux. So lots of acidic fruits, citrus fruit. The classic other ones will be sort of high in fats, like pastry, for example, I know often causes people to have bad reflux. And then in adults would be things like alcohol, caffeine, things like that. Coming on to medicines, how do we manage reflux with medicines? Well, that's changed a little bit in the last few years because ranitidine, which was one of our staple drugs that we used, has been withdrawn. So generally, babies now are often started on Omeprazole and those, which is a type of PPI, proton pump inhibitor, and there are other ones, esomeprazole, lansoprazole, pantoprazole, and they're often started early but can continue right the way through to adulthood, and many people are on those. They reduce the amount of acid that the stomach secretes. And so that's particularly helpful if you have heartburn or you've got symptoms of esophagitis, which is the inflammation of the esophagus. So the acid has come up out of the stomach and is irritating the gullet, the esophagus. And that can cause damage to the esophagus, but also can cause pain and indigestion. So some people refer to that, medical term is dyspepsia. So, and also children and adults can describe feeling or tasting acid in their mouth. And again, that's acid brash. And all of those things can be helped, particularly with an acid suppressant like a PPI. So that's the mainstay of medicines now for reflux. But there are other drugs that are still used. Coming on to those, domperidone is a prokinetic that works on the stomach and encourages the stomach to empty better. And then that can then mean there's less contents in the stomach to reflux back up. So I have sort of mixed views on that, really. Some parents swear by it and tell me it's great, it really helps their children. Others say it doesn't make any difference. And the evidence base for it is not so great, actually. And it has to be taken usually 3 times a day, and you need an ECG before it. So it's kind of often a second line or we're really struggling. What other medicines? Well, Gaviscon is still pretty useful. It can be used in babies' bottles, as we talked about before, but can also be taken as a liquid or a chew at home, and many adults will know they've taken that themselves. But that can, I have some older children who take that as a sort of symptom relief. They've had a very fatty meal, or they've I don't know, been to a party and then they've got bad symptoms of reflux, then they will have a Gaviscon. So that can be used on a sort of as and when basis, really. So that's covered the sort of simple things, changing the feeding, the positioning, avoiding certain foods, the medicines. And then the other thing to say, I think, at this point with managing reflux is it's important to think laterally. And if we're not getting on top of reflux with the simple measures and medicines, then it's important to seek medical advice and that's where regular follow-up with a surgeon or gastroenterologist is really important, because it might be that there's other things going on. So we need to check there's no damage to the esophagus. There could be things that are causing the reflux to be worse, like a hiatus hernia, or there could be strictures or erosions or ulcers and things like that. So if it's particularly troublesome, the reflux, then I suggest very much that a review and contacting health professional, your health professional, to ask to be seen for a follow-up. And then after that, they can recommend what sort of investigations. And if things are really bad, that often means an endoscopy. So in children means going to sleep, having the camera, having a look at the inside at the esophagus and the stomach, and saying, is there any sign of reflux there, and taking biopsies as well. So that sort of covers that bit. And then it's final we'll touch on, but I know we're going to come to later, that if reflux is really problematic, because reflux can not just always cause symptoms, but sometimes actually can cause really bad complications, particularly in babies, you need to do surgery if reflux is unmanageable with the medicines and those simple things we talked about. And that's usually in the form of a fundoplication, which we're going to touch on later, but that can be very helpful and can really shut that down. And it's particularly helpful if you've got a hiatus hernia or sort of strictures that you can't get on top of the strictures. Yeah, I think that's everything. Bit of a long
That's great, thank you. I mean, a lot of information there. Carrying on the theme with reflux, and obviously you've talked about strictures and fundoplications and things like that, which is probably the worst end of it. Many members, though, have asked whether reflux tends to improve as the children get older.
Yes, yeah, and thankfully it does, actually. So what I did there in that first question was to just paint the sort of an overview, really, and there was a lot to which we're now going to touch on at various times. But thankfully reflux does get better. And reflux is, it's probably safe to say that all babies when they're born reflux, and we know they do, and you can see that when they posset milk back up. But the changes in the body as you grow older mean that reflux does improve, and that's the same for children with OA TOF. So there's a number of reasons, but briefly they are that you become more upright, you spend more time. Initially you sit up and then you start standing. Your muscles get stronger, which we touched on earlier. So particularly the core muscles, the diaphragm, all of those sorts of things. And obviously the esophagus elongates. So as you grow rapidly in that first year, the distance between your mouth and your stomach increases. And hence gravity is on your side there, keeping things down. And finally, when you transition to a solid diet or predominantly solid diet, that can help as well. And that sort of explains why early weaning can often be helpful, because moving to solids can often really treat those reflux symptoms as well.
Okay, that's great, thank you. Carrying on, we've had a question from a mum of a 16-year-old TOF. She says, my son has been on a daily dose of 120 milligrams of lansoprazole for 28 days. And it's caused damage to the reflux, damage to the esophagus. This has now been reduced to 60 milligrams, yet he continues to have heartburn daily. Will that ever go away? And I mean, obviously they're waiting a review. So any thoughts?
Yes, so those are clearly very high doses. Obviously, I don't know his case in detail, and his professionals do. So there'll be, I assume, a very good reason why those very high doses. So just to put it into context, a standard adult dose of lansoprazole will be 30 milligrams. So we're on sort of 4 times the dose there, and then down to double the dose. In children, we often use 15, smaller children. I think my gut feeling from the little I know there is that presumably, it mentions here about, you mentioned, didn't you, that there was damage to esophagus, and hence they'd been given that very high doses just for a month. And that sounds like a good plan if you've got damage. So presumably that's erosive esophagitis. That's when the inflammation of the esophagus is significant enough that it's damaged the lining and taken some of the lining away. So a very high dose could help cure that. I think the key thing is that you need to check whether that's worked really. So this difficult for me to say with certainty, because I don't know the full details, as I said, but I would have thought a repeat endoscopy would be a good idea to check that that's worked, and probably biopsies as well, and to check it's not worked, and to check there aren't other changes such as Barrett's esophagus. And finally, if it hasn't worked, then it's exploring other options really, so guided by the biopsies, but perhaps even if it hasn't worked and you've had to remain on a 60 milligram dose for a long time, then perhaps if the symptoms are still bad, then that might be a time to discuss surgery and consider fundoplication if he hasn't already had one.
Okay, that's great, thank you. Right, so the next one, a number of questions have been asked about silent reflux and the benefits of taking omeprazole as a precaution. So for one example, one member says, my 1.5-year-old doesn't show any signs of reflux, but she's on 15 milligrams of omeprazole daily. Is it safe to try and wean her off it, or should we continue taking it? And obviously, perhaps you can explain to everybody who's listening what silent reflux actually is.
Okay, yeah. Okay, well, let's deal with one of those once at a time. So I'll talk about silent reflux, and then I'll talk about this case. So silent reflux is an imprecise term that I'm not particularly keen on myself, because it means different things to different people. Often people use it to say, well, they've got reflux, but they haven't got symptoms, which makes sense, silent reflux. But actually, I think when it's used in medical terms, silent reflux, it generally means what's called laryngotracheal reflux. So it's often diagnosed by ENT surgeons, and it means that there's reflux up the esophagus of the gastric contents, and that may be acidic still. And then it's not causing the usual symptoms of reflux. So it's not causing heartburn or regurgitation or indigestion or the acid, things like that. But what so it's called silent because it's not manifesting as those normal common things, but it is then going over in towards the larynx, which is the voice box, and hence can cause problems and symptoms from that. So classically, it will cause hoarse voice, or a sensation of a lump in the throat, or you're having to keep clearing your throat, or lots of coughing. So it might get mistaken for another thing like having lots of viruses or things like that. And you can also get even things like postnasal drip. You get that little drip behind the throat from your back of your nose. So that's silent reflux. It can be seen sometimes when ENT surgeons put a little flexible scope up the nose and look down the back and can see the vocal cords are angry and red and have changes on them. So yeah, that's silent reflux, or true silent reflux, laryngotracheal reflux. In this case, so 1.5-year-old who doesn't have reflux symptoms is on 15 milligrams of omeprazole.
Yeah.
Again, difficult for me to say with certainty about whether or not they should be weaned off, because I don't know the case in detail, but what I will say is that if there are no symptoms and no changes on endoscopy or other problems, then I would have thought it's certainly worth considering weaning that with the help of your doctors. Our policy, well, I'll first say that there's no agreement on the use of omeprazole as a preventer of strictures, and there's no widespread agreement, and often little sort of research papers will pop up and say PPIs, omeprazole doesn't, or PPIs don't prevent strictures at the join where the join of the esophagus was done. And there's a recent paper, for example, in the last couple of months that's come out saying that from America. But all of these they're not good evidence. They're not high quality evidence, and they're very susceptible to biases and sort of the effect of what we call confounding factors. So actually in the UK, we're leading a trial which TOFs is supporting called TOAST, and that's going to randomize babies to have a PPI or not have a PPI, and you won't know which one you're having, because we need to answer this question once and for all, whether it's good to be on that PPI for that first year. So that's just to touch on, we don't know the answer at the moment. We're hoping to find the answer, whether you should stay on them as a preventer. Our policy in Manchester, that myself and my two colleagues do, we tend to have all babies on a PPI for the first year. And if they're completely symptom-free, completely well, weaned, and they're doing fine and not had problems with strictures, then I would stop it then. Just stop it. So in this case, if you're 1.5, the baby's 1.5 and there's no symptoms and there's no problems with strictures, then, or lots of chest infection things, then yes, I think it probably would be reasonable to wean that with under the consultation of the doctor.
Okay, thanks for that. Just to follow up from that, is it possible to use Gaviscon rather than omeprazole as a preventative, or would you normally go down the sort of omeprazole lansoprazole route?
Yeah, I don't think it's the same really. I don't, because Gaviscon is not really going to reduce the acid. It's just going to coat the lining of the esophagus really. So in theory, there's no reason to say why. Well, I'm not sure it's been tested whether it works, but I wouldn't normally do that. I know people do say, well, regular Gaviscon, and I don't think there's any problem with regular Gaviscon. If it's needed, it can cause constipation in babies, and I remember my daughter had shocking constipation when we had to stop it. But it's not. I think it's probably omeprazole is a better preventer, even if it is a preventer. Yeah.
Okay. Right. So we're going to move on to vomiting, and we've had one question specifically about vomiting, where somebody's 4-year-old daughter keeps having sickness episodes every 4 to 8 weeks, which ends up with her vomiting for around about 5 to 10 days. They have no warning signs. Have you got any suggestions?
It's a tricky one, that. Again, I'm always a little bit hesitant to speculate, because I don't know a few details, and I haven't met this little one, but I think there's certain things to bear in mind. I'll leave it at that really. That if you've got bad reflux, and that may be, silent in inverted commas, as in it doesn't normally manifest, but you are refluxing more than a normal child, because all babies and small children reflux to a degree, and that gets better, as we talked about. But at 4, generally shouldn't be refluxing. It might be that this little one has, is very susceptible to vomiting, so vomits easily because of their underlying mechanisms of their esophagus and the mechanics of their esophagus and their stomach. So it could be, and again, speculating that whenever they catch a bug, a normal GI bug, that they're just more susceptible to vomiting. So children generally, vomit at the drop of a hat, really, and some more than others. Some children, they bang their head, they vomit, or they, go in the car, they vomit, or they, eat too much, they vomit, whereas adults tend to be less so. So you've already got a population of children who do that, some don't. And then if you put the esophageal atresia on top of that, it might be that she's catching, or they're catching bugs off other children and doing that. Again, that might not be the case. It's a little bit unusual that they last 5 to 10 days, because most vomiting bugs don't last that long. So certainly that would be unusual, and also unlucky to keep having this happen every 4 to 8 weeks. So it certainly warrants a bit of a think, and perhaps a consultation with someone, a paediatrician or a paediatric surgeon, and looking into a bit more. I mean, the only other thing I would say here is it'd be interesting to know whether they were on a PPI, like Omeprazole, because there is some evidence that PPIs, by dropping the acid, can make you more susceptible to infections of the GI tract. So that was in older people. There's been the Clostridium difficile. That was always an association. But actually, and we may come to this later, that the only thing in the biggest study, in the biggest trials, was that you can get more GI infections, essentially like tummy bugs, if you're taking PPIs.
Okay, that's brilliant. Thank you. I'm going to hand over to Di for a few questions while we talk about strictures. Di?
Thanks, Duncan. Hello, everybody. And hi, Nick. Thanks ever so much for giving us your time this evening and for answering those questions so comprehensively as well. I feel I learned a lot about reflux. And I've got a number of questions to put to you now about another really common topic that pops up very frequently, and that relates to strictures, which we hear are common complications post-repair. So obviously they're a concern for many parents, and perhaps you could start off by defining exactly what a stricture is, and perhaps telling us the signs that parents should look out for in terms of spotting a stricture, and sharing with us what general guidance you give to parents post-repair in relation to these.
Okay, yeah, thanks, Anne. So strictures are a narrowing of the esophagus, and because the esophagus is a tube, they are usually a cylindrical narrowing of that. And when we refer to strictures in esophageal atresia and post-repair, they generally refer to an anastomotic. An anastomotic just is a surgical term for join. So whenever we take the 2 tubes and do the circle of stitches to join it, that area scar, we all heal by scarring. You cut your skin, you can see that you scar. The scars contract, and whenever we join bowel or esophagus or ureter or any tubular organ, that is always susceptible to narrowing. And it's particularly susceptible narrowing if you've had to really pull the 2 ends together, which is often the case with esophageal atresia, and if the blood supply isn't great to them. And so there are 2 things that we get in the esophagus. We get tension, so things being pulled together when we join it in the baby, and the blood supply can be poor. And when you've got those things, you get more scarring and more narrowing, and that can then cause problems with what we call strictures, with that narrowing, and that's an anastomotic. We also use the word stricture in esophageal atresia and esophageal surgery to mean narrowings from other things like reflux. So it tends to be lower down where you get narrowings due to the effects of reflux. But for the most part, we're dealing with these anastomotic strictures, and we'll focus on that today. Common signs. So in older children, they're actually easier to spot because they'll complain of swallowing difficulties, dysphagia, and things getting stuck. And in younger children, it can be trickier. And in babies, particularly because they're drinking milk, they may carry on feeding. So it can be quite subtle to know when they've got a stricture. But the things to look out for, if it's a bad stricture, they will drool more because they can't swallow their saliva as well. And their bottles or breastfeeds will take longer. So they're taking much longer to finish a feed. And hence, that might be a spot from mum or dad. And they may bring feedback. So if it's coming out too fast, either from the breast or from the bottle, it can then just overflow because it can't get past that narrowing. It's like having a narrowing in a pipe, you know, that you taps on too much and it just comes over the top. So in a baby, those are the things to look out for. At this point, it's probably just worth touching on that. I think strictures can be one of those things that if you don't look for them, you don't find them. And I know that we're sometimes a little bit skeptical when people publish rates of strictures in studies of esophageal atresia because they're not sort of looking for them. And your threshold for intervening and having a look with the camera can be different wherever you are. And I think we have quite a low threshold. So if a baby's struggling particularly, then we'll look with a camera early and then do a balloon dilatation, because I think if you get on top of them earlier, then you can do better. In the older child, I think most parents of children with esophageal atresia will know that the sticky is that thing that's feared most and is often experienced. And that sticky, where something gets stuck, if there is a stricture that's getting worse, that might happen more frequently. So they get more stickies, or they can feel things are getting stuck and then going down, or things are going slower, or taking a long time to eat a meal, or needing more drinks than usual. We need to know that on the background of the esophagus itself, even if it's not narrowed, won't be normal. So you'll often hear that referred to as dysmotility, and that means the esophagus normally, like a snake swallowing something, when you see a picture of a snake and it does that coordinated squeezing from top to bottom. We know that in esophageal atresia, even if you haven't got a stricture, it doesn't work normally, and hence some children will get things stuck or feel things getting stuck even though there's no stricture. And really the only ways to look for that are either to look with the camera, which means going to sleep, but the other way in bigger children is to get them to swallow some contrast and look for the narrowing, and that can be helpful as well, and also can show the dysmotility. I think that's what we were. Was there another bit about what we to do about them? How to minimize the risk? Should we talk about that now?
Yeah. Yes, please.
So it comes a little bit back to what we were talking about in the last one about PPIs and minimizing risk and the evidence for preventing. There isn't great evidence to say that all children need it. We feel that you should have, if you are struggling with strictures, so you've had a stricture that's needed dilating and perhaps that's then needed another dilatation, then we would say that you should be on a PPI, because the theory at least is that the acid coming up can then make that healing of that stricture and irritate it more and then stricture down again. And certainly we do find that if you help the reflux, you can help the strictures. And probably the best description of that came to me when I was training. That was one of the senior surgeons I trained with was saying that if you've got a really bad stricture in a TOF that you can't get on top of with a balloon dilatation, then he always said, if you do a fundoplication, they melt away, and certainly I've seen that where, particularly in a child I had with a hiatus hernia and terrible reflux, when I did the fundoplication, their stricture just healed itself. So I think that's really important to say that if you've got problematic strictures, then I think a PPI is worth doing.
That's interesting. And of course, we come back to fundoplications later on as well. But following on from that question, Nick, a mum of a 5-year-old child born with a white TOF has said that her child often gets food stuck. So whenever she drinks, the fluid comes back up her nose, and it's a total blockage. But at other times, she's absolutely fine. So in your opinion, does that sound like that might be stricture forming, and does she need a stretch?
It certainly could be. It's likely to be a stricture or dysmotility that unfortunately is more difficult to treat. Again, anecdotally, and certainly I was always taught this, that even if it is dysmotility, a stretch can sometimes help that. So you find that even if you put the child's asleep and you do a stretch with a balloon, and you say to the parents, well, actually there was hardly any narrowing there at all, and when we put the balloons are shaped like a sausage, really, and they're on we put a wire down and then we put them over the wire, so they're on a very fine tube, and then you have like a sausage. And when there's a stricture, you can see like an egg timer shape, what we call a waist on the balloon, and sometimes there'll be no waist at all, or we'll blow the balloon up, and then mum and dad will come back and say, a different child, absolutely brilliant, you know. And so it's almost, I don't want by that stretching that you help with dysmotility. I'm certainly not saying that dysmotility should be treated by stretching, but no. What we do find, if we are going down that stretch route, we can improve things, even if that doesn't seem to be. But the other way of looking, obviously, as we said before, would be to do with that X-ray barium swallow or contrast swallow. If she's struggling, I think, and that depends a little bit on your 5-year-old, really, and your team. Some people will do a lot of contrast swallows, some centres, others will go for the camera as a first line, but obviously that does mean a general anaesthetic. So in the bigger child, actually, a contrast can be really reassuring. It might say that there's no stricture, so this is likely dysmotility.
Thank you. Moving on then to the next question, Nick, and this relates to babies. Many have issues when taking a bottle and can struggle with the flow, even with a newborn teat. And one parent has asked us if this improves with age and if there's anything they can do in the meantime. And by the way, this child has just had his first stretch after a stricture was identified. Okay,
so certainly the stricture won't have been helping things. So if you're poor, it's that tap analogy again. If the tap's on at a high rate and it's only going through a really thin pipe, then it's going to come out of the top. So the clearance further down is really important. I think in terms of not managing the flow, I'd probably defer this to SALT, actually, the speech and language therapy, and I'd recommend that their input, they're excellent, and we often have specialist neonatal at the bigger centres, also the tertiary centres, rather than the local hospital. There'll be a neonatal speech and language therapist who's very experienced in esophageal atresia, probably, and they'll be able to offer advice. But sometimes a thicker fluid, as we talked about before, and that doesn't have to be Gaviscon, it could be Carabao or Thick and Easy or something, and that can, or a different milk. You know, some milks are thicker than others as well. So I think even if it's a low flow teat and we've ruled out the stricture, then I'd go with the SALT line and ask their advice, and they should be able to do it, even if it's a remote consultation. They probably don't need to meet you and examine, but maybe able to give video or telephone advice as well.
That's useful. Thank you. So, Nick, a number of questions have been sent in around whether children grow out of needing dilatations, or the chances are that they're going to be required all throughout their lives. And is there anything that can be done to prevent strictures from reoccurring?
So, yeah, again, it's slightly a parallel with reflux. Thankfully, yes, they do get better. And if I wanted to, you know, a classic baby or baby who's with esophageal atresia would be needing a number of stretches in the first 1 or 2 years of life, and then really weaning down. And then it's very rare that I would stretch anyone over the age of 5 or probably even 3 or 4. So most of the stretches we do are in the baby, that first couple of years. And for some reason, and it's likely to do with the growth, and just because the esophagus is just that much bigger, and probably, and it's difficult to prove this, being on solid food, it's almost that having that swallowing of the big boluses of food keeps it open. I know that sounds odd, really, but certainly we do find that babies and children, when they're weaned, seem to get less problems. And And there's definitely cases I can remember in the last couple of years who've had terrible strictures because they've had really difficult surgery and really difficult joints where the upper pouch has been huge compared to the tiny lower pouch. So you've had this kind of funnel, and we've started with we've only been able to stretch tiny amounts with 6 or 8 millimeters balloons. And then a year later, they're just a normal child, normal baby, normal swallowing, weaned. So what I would say is it may seem like the end of the world early on, but that can rapidly change to have a really good function later on. Yeah, so,
sounds very encouraging, I'm sure,
yeah,
for a lot of parents to hear that. If strictures do reoccur, are there non-surgical options to deal with that?
So it depends what you mean by surgery. And certainly there are a few options other than dilatation. You know, the really difficult ones can need actual surgery to remove them. That's exceedingly rare now, I think, partly due to the stretchers are so good and the medicines are good at trying to sort of calm those down, but not really, to be honest. If they do occur, then the only real way of dealing with them is to do an esophageal stretch, dilatation, or very rarely, you may need them removing, which is big surgery to excise that bit of esophagus. But I can only think of hearing about them as I've done that once in maybe 10-15 years, so I don't think it's worth dwelling on that really. But no, I'm afraid there's not really any way that I know of. Interestingly, there are different approaches to that dilatation, and there are, in very problematic strictures, in smaller children and infants, people have left balloons down in the esophagus and just inflated them daily, usually in a hospital environment. And so that's described. And the Americans have also published something about using a little knife endoscopically from the inside with the camera to sort of cut the stricture from the inside. But I haven't got any experience of that, and it's not something we've ever needed to do, really.
And is it something that's done in the UK?
I haven't heard of anyone using an endoscopic knife. We've used that for different things, but not strictly an anastomotic stricture that I'm aware of. It may have been done, but I'm not aware of it.
So Nick, the final question in relation to this is, as the child gets older, even if they've never had reflux or needed a stricture before, is it possible that, or needed dilatation, is it possible that reflux can become an issue or a stricture develop at a later date, at around 5 or 6? I think from what you're saying, unlikely, but
it's unusual. It is very unusual, actually. It can occur, but it is very rare. I can't think of it occurring. It would normally, I think, the only times I can think of it that is if a child hasn't been followed up correctly, perhaps, or not regularly enough, and they've been running into problems slowly, and maybe that wasn't picked up. And then when the diet's changed and they're eating more difficult foods like meat or bread or things that we know that are classic things to getting stuck, it might be that it's actually the stricture's been there for ages and it hasn't been picked up, and it's just got worse and worse. And if they've got bad reflux, that it's become a really difficult stricture. The one that can occur is the reflux stricture. So that is usually lower in the esophagus, and because of that continual acid damage, you can get a narrowing. And they can be tricky to deal with, but they can be dilated and a PPI, high dose PPI used, and then very occasionally they need dealing with surgery, for example, like fundoplication.
And that moves us on to our next topic, and I know you touched briefly on this earlier when you talked about those cases where reflux was really unmanageable. Mm-hmm. We have a couple of questions really in relation to fundoplications. And the first one is to ask you to give us a brief explanation of what a Nissen's fundoplication is and of its benefits.
Okay, so fundoplication can mean there's different types. Most commonly, it's a Nissen's, so that they're quite right there. So that's the most commonly done, and that's a type, and is a name. They involve wrapping the fundus of the stomach, which is the top of the stomach, round the esophagus, to treat reflux, and they work. I think the misconception is that they cause a narrowing. That's not the idea. So it's really important to get that across, because people are often frightened of fundoplication because they think we're creating a narrowing, and they, parents say to me, well, my child will be able to feed again. And what it involves is an operation from the tummy, usually with keyhole surgery now. I can't, we exceedingly rarely do it with open surgery, only if the child's had lots and lots of surgery before in the abdomen and the adhesions are too bad, but that's very rare. So it's normally the keyhole, and it involves freeing up the top of the stomach, making a little window behind it, and then passing that fundus around the back, and then sort of fastening it to itself. And what I think is probably the best thing I do is if I find a picture, because it's a really difficult thing to describe, but I'll find a picture and hold it up to the camera. But basically, I don't know, it's not really projecting well to the light, but you can just
that's
do
not
that.
bad. That's good.
So that's the esophagus at the top, and then wrap of the fundus going around the back, and then fastening it to itself with a couple of stitches, or 3 stitches usually. That's the Nissan is a 360-degree wrap, so that all of the esophagus has fundus around it. And there are other types which all have eponymous names, but we don't usually use those. We occasionally use them in other things. So the important thing to say is that wrap of esophagus, sorry, of fundus around the esophagus shouldn't be tight, it shouldn't be narrowing, and it should be floppy, basically. And it works because it recreates some of the body's sort of natural anti-reflux mechanisms. So it recreates the right angles. It makes sure the esophagus is in the abdomen, the lower bit, the junction is in the abdomen rather than up in the chest. And it creates an area of sort of high pressure when the stomach fills, that wrap gets things in it, and that then creates, when the stomach fills, an area of high pressure. So there's a number of reasons why it works. It's got a bit of bad press, fundoplication, largely in neurologically impaired children. So we used to do this operation all the time in children with cerebral palsy and reflux from neurological reasons. And because people were doing it on loads and loads of children, often it didn't work, and it caused problems. Actually, it is very useful operation, and it's particularly useful in some children, even the neurologically impaired ones we find, but mainly in this group, in esophageal atresia, it is really useful, and it tends to work very well. But it is surgery, it is major surgery, and there are risks associated with it. But it is useful if you've got problems like the stomach being in the chest, a hiatus hernia, or part of the stomach, or you've got a stricture that won't heal, or you've got reflux that's causing damage to the esophagus. And in those situations, whilst there is some risk of the surgery, those risks are outweighed by the benefit of treating those either the damage or the ongoing problems. And just to touch quickly, there are some babies particularly that have such bad reflux that it causes them to have it go over into their lungs, and then they have either they stop breathing and they have what people used to call ALTs, so acute life-threatening events, or they can have lots of chest infections, or they don't grow because they're bringing up things. So in those, an early fundoplication in infants is sometimes needed to address those really serious problems. So that's what a fundoplication is. Nissan's is the 360. It's usually keyhole, and it's just about getting the right, making that decision right, really, that's right for that child and that baby. And it's, yeah.
And is there a lifespan? How long does a fundoplication usually last?
That's really difficult to answer in precise terms, but what I'd say is it's very rare that we would have to redo it, or that it stopped working, that then, having worked well, the child then got into difficulties again. So it lasts long enough, in my experience, to get beyond all of this. And in the neurologically impaired, I've got children who have had it for many years or decades, and are actually still working well. It can fail, and it can come undone, or it can slip the wrap. but I think if it's done well, those risks are low, and if it's done nice and loose, and I think there's like anything, there's fundoplications and there's fundoplications, but there's some principles that I think people are learning that can minimize those risks of failure or slipping and things like that.
Thank you. I'm moving on now to my final couple of questions, Nick. And these relate to diet in relation to managing reflux. And a few members have asked about managing reflux with diet and whether this can lead to their children perhaps coming off their PPIs. What's your experience in relation to that?
Yes, I think like a lot of these, it's difficult to get beyond the sort of anecdotes and the sort of reports from parents. And actually that's what matters the most, really. It doesn't matter what the research shows, really. It's what parents and children come back and tell you. So my experience is that there are definitely foods, and I mentioned a lot of them earlier, but I've got a patient who sticks out to my mind, who, they tell me, oh, well, if she has fish and chips, she knows she's going to be terrible at night and she'll take some Gaviscon and things like that. So it's those spicy foods, fatty foods, the acidic foods, the caffeine, the alcohol, obviously later. So if you can avoid those things, and then it again touching in the younger child, the infant, it might be changing the milk, and people do find that a more hydrolyzed formula, so a more broken down one, can cause less problems. And certainly in general, baby reflux, that's very much in vogue now. Is the first line is to change the milk.
And then just one last question, specific question from a parent of a teenager who's now 14. And she's stopped taking her medication, and she's tired of taking them. Not unusual, we hear, for teenagers actually to be saying that. And she was on 20 milligrams of Omeprazole, fexofenadine hydrochloride, and Avamys nasal spray. And she's now having tummy aches, which she's attributing to being lactose intolerant. Do you have any suggestions that might help her?
That's a really difficult one for me to answer, because I guess it's more of a gastroenterology type thing, that one, particularly the allergy medicines like that's an antihistamine, I think, and the nasal spray, I'm presuming that is sort of an allergy thing as well. So I'm not sure about those. In terms of the tummy aches, they could be completely unrelated to the esophagus or reflux, and hence it certainly would be worth, if she's not getting symptoms of reflux per se. So abdominal pain on its own is unusual from reflux. That'd be more gastritis, or if it was to do with the acid. So reflux with the esophageal atresia, if she's not getting the sort of either heartburn or indigestion or acid or problems with the chest, or those are or bringing things back, or then maybe it is nothing to do with the reflux and the tummy pains, and then stopping the PPI would be very reasonable. So I think lactose intolerance at that age, again, a little bit tricky to prove, and can overlap with other food intolerances and things like irritable bowel syndrome and other food intolerances. So again, that's more of a trial and error thing, really. I guess trying a lactose-free or lactose-reduced diet can help. And I think when you get into that age, it's slightly less problematic. Obviously more problematic in where you've got a lot of milk and things in the diet. So I think it would be reasonable to try and reduce the lactose and see whether that helps. I think at that age as well, I'd just touch on, when was her last assessment, and has she ever had any endoscopies or repeat endoscopies, because she's getting towards transition time, and we'd recommend at least one set of biopsies prior to transition, and just to check there's no changes in the lower esophagus that then need to be watched in adulthood. It's a whole different subject and something we haven't sorted yet in the UK. But transition to adulthood, the adult services don't have the capacity to keep everyone with esophageal atresia under yearly follow-up and endoscopy. But if we can show there are changes in those teenage years, then we can refer the adults with some evidence that they definitely need to be kept under surveillance and under endoscopy surveillance. So I would say that if that's certainly worth considering if she hasn't had an endoscopy, and that might help us find out what a tummy ache is at the same time as well.
That's very useful. Thanks very much, Nick. I'm going to pass you back to Duncan now.
Thanks, Di. Thanks, Nick, for those. Right, I've got one final question, and if we get a chance, we'll answer some of the questions in the chat, but we'll obviously see what we get up to. Now, this is a long question that people often want answering, and it's one that is probably at the forefront of most people's minds. And we often get asked this: what are the benefits versus the risks of taking PPIs long term, and what would be your general guidance regarding this?
So it is a bit of a hot topic, and every year more and more papers come out about PPIs, and what I would say is that overall they are very safe, I believe, and I think a lot of the previous alarming sort of reports that have caused alarm weren't really tested well. So they were associations. So the ones, there's all sorts of things come out, but I'm thinking that the sort of people have raised concerns about associating with long-term PPI use, and everything from fractures to kidney problems to you name it, but sort of heart problems, stroke problems, cancer, etc., etc. And each of those associations between the two have been reported based on essentially looking at a group of patients who may have already been predisposed to those problems, if you like. So they weren't, I touched on it earlier, but they weren't good studies that took all of those potential other factors into account. So the thing that I always go back to is I think the best study, which was a randomized trial in 2019, which means they had 17,500 patients in 30 odd countries, I think it was. It's a huge study, and they gave some of them a PPI and some of them not a PPI, just a placebo, no sugar tablet. And what these were in all sorts of adults, so not just a certain group who might have a problem and hence might be more predisposed to getting other problems. And they found that there was no increased risk of any of these things. So we're talking pneumonia, problems in the stomach, kidney disease, diabetes, problems with the lungs, dementia, cardiovascular disease, and cancer, and death. And in those two groups of 17,500 people, there was no difference in those things. So I think that's really super reassuring, to be honest, really reassuring. And the only thing they showed a slight increase in was that GI infections. So, getting essentially more bugs, tummy bugs and things. So are they safe? Absolutely. We've never been able to prove in a big study like that. And that was with 3 years of follow-up. So that's another important thing. If they were going to find something, you would expect in 3 years they would have found something in that number of patients, even if it was a rare thing. So I'm really reassured by that, and I hope others are too. What I would say though is obviously we shouldn't be on any medicines that we don't need them. So the indications for PPI need to be carefully considered. And as I say, in that, our policy is to use it for the first year in everyone and then wean it as appropriate. So if you're symptom free and not having any problems with strictures or lots of other chest infection problems, then wean it. If you're still symptomatic, then continue it. And this comes back to that thing time and time again we say, don't you need regular follow-up. You need to be seeing a doctor who's thinking about these things and thinking about your Omeprazole and saying, can we stop that yet? Are we in a position to do that? But also following it up and also thinking about surveillance later. So it's, for me, it's all part of a package really. It's the follow-up and the PPI and the surveillance and things.
Okay, that's great, thank you. Right, we've got time for a couple of questions, but they're gonna have to be, I'm gonna have to cut you down to very short answers. So first one was, can reflux resemble coffee-like colours like black sludge?
Yes, that it usually means, so dark fluid is usually old blood, so it could mean that there is some irritation or inflammation there that's then caused a little bit of bleeding.
Okay. And then one which I'm really intrigued about, because I never thought of this, is how long can you be on omeprazole until it affects your bone density?
So again, that comes back to exactly what I was just talking about. People think that because people speculate because you need acid to absorb calcium, that you don't absorb much calcium and you get lower bones and fractures. But the biggest study that I just talked about didn't show any differences in fractures or that. They didn't specifically look at bone density, from what I understand, as in DEXA scans, but there was no sort of so from what I understand, I don't think that has been proven that it does cause that. And I certainly don't know of any duration of time. Okay.
This one, I thought my daughter had a lot of dilatations with over 40, but this one, this lady's daughter's 3 years old. She's had over 100 dilatations with hardly any progress. The stricture is approximately 6 centimeters long. Is the repeat dilatations damaging the esophagus tissue, and should it be causing it to be less functional?
Again, it's difficult to comment on individual cases, but that sounds very unusual and concerning, really. To have that many dilatations, and most strictures aren't anywhere near that long, so that sounds like a long area of damaged esophagus. And I think probably a rethink of the approach taken there is needed, and potentially trying something else and complex and difficult. But I think definitely needs a more of a thought on that one, and maybe a different approach. Yeah. If it's not worked 100 times, it's unlikely to work.
Yeah. Would you suggest a gastric pull or anything like that?
That's very drastic. I wouldn't go straight for that, I think. But certainly it's a long area to bridge, so would need thinking about. Yeah.
Okay, and a quick one, because then we're running out of time, but for all the other questions that we've got, obviously we'll try and get some answers, but most of them I would actually say go and speak to your GP, and obviously speak to your consultants, because they will be able to answer all these questions anyway for you. But are there any signs that a fundo's not worked, or it may have slipped, or it may have come undone? Would there be pain, or would it simply be that the reflux would return?
I guess it depends on what symptom the fundo was done for. So if the child was bringing up lots of volume of milk and regurgitating or vomiting, then that coming back would show that it stopped working. Or if it was done for other things like heartburn or damage to the esophagus, then when you looked because there was an esophagitis problem, then that may return. The best way to look whether it's slipped is to do a contrast study, and on that swallow you can then get the contrast and see whether the wrap is in the right place or not.
Okay. Yeah, we've only got a couple more. So another lady, TOF, suffers from truffle sickness, and obviously found that the ingredients in Piriton can exuberate reflux and often cause skin conditions. Is there anything they could take for travel sickness because they're now becoming 6 years old in January, that won't exuberate it like Piriton?
I'm not sure about that one. Can I just?
Yeah, we can answer that one another time and come back to it.
I think I've never heard of Piriton causing reflux. That's probably the most I can say about that, I'm afraid.
Okay, we can try and come with an answer for that one. Yeah. That's not a problem. So my daughter's been 16 months under the care of our MCH. We've tried stopping the omeprazole, but she began with symptoms again, so coughing, regurgitating in bed. Would you recommend an investigation/pH study? I think the answer is yes.
Yeah, what I would say is I don't recognise the name, so I don't think it's one of my people, but there's only 3 of us, so that should be in the follow-up. So if you ring our secretary on 0161 701 2194, and that's the same secretary for all 3 of the TOF surgeons, we'll get you in and make an assessment. If you ring Sophie, we'll sort that out. Okay, thanks for that. And then we are going to have to say this is the final one. We have a 3-month-old. He's 7. His brother's 7, and he was a tough OA. The newborn is having choking episodes since being born, exclusively breastfed. He's had an NG tube passed, an X-ray, and when born, due to his brother being born with an OA, tough OA, all seemed to be going well.
but do you think they should actually go back and have something looked into on that?
So esophageal atresia doesn't normally run in families, but there have been episodes, and it has happened. You can get some things that aren't actually a TOF or an esophageal atresia, but are congenital narrowings. When I say congenital, it means you're born with it, and you can have a narrowing, so either a piece of cartilage or some thickening of the muscle in the esophagus, and that can cause a congenital narrowing. So if we're continuing to choke, then yes, I would get seen and consider a contrast swallow where you do the dye test, and that would show any structural problems. Failing that, then things like salt and things, I think, would be good.
Yeah, okay. Right, okay, it is 8 o'clock. Nick, I know you're very busy, and, you know, we are ever so grateful for you giving your time tonight and answering so many questions so well for us. So on behalf of TOFs, thank you very much for giving up your time tonight. Obviously, to everybody whose questions we haven't had a chance to answer, please do get in touch with the office. We have got one person who's been on the call from Australia. I would say get in touch with our office, and obviously we can help and advise. And obviously there are local TOF groups in Australia as well that can help there. But, you know, thank you for your time. Thank you for joining us, and thank you for everybody else. Please remember to fill out the evaluation form, and obviously look out for the next event in November. Thank you all. Good night.